So I remember putting on these sort of spacesuit type things, gloves, gowns, masks, caps, and traipsing into this patient room with 3 or 4 other resident physicians and attending, and not really, again, understanding exactly what we were dealing with, except this person had, again, this immune deficiency disease, was probably going to die, and was quite sick.
The first time I heard of the condition, it was probably called GRID, or some other acronym, as opposed to AIDS or HIV. HIV didn't exist, it was really AIDS, an acquired immunodeficiency syndrome, so we really didn't know what caused it. We epidemiologists knew this was probably an infectious agent, probably a virus, but that was guesswork based on the fingerprints that this epidemic led.
And there was no treatment for HIV. We didn't even call it that. We called it AIDS starting in 1982, but there was no treatment. We didn't even know what caused it until March of '85. That's when we had a test for it. So in that time between '83 and late '85, when people came to me, they had an AIDS diagnosis because there was no way of knowing that they were infected before then. And consequently, the life survival was less than 6 months. I could certify anybody for hospice, which is a less than 6 months survival based simply on their diagnosis. And what a lot of people, I think, have forgotten, and young ones don't really realize, is that not only did we not have any treatment for the virus that was causing AIDS, we didn't have good treatment for most of the opportunistic infections that were showing up.
And most were very close to dying. I would say within a year, anywhere from a month to 6 months to a year of dying.
People would come in with things like pneumocystis pneumonia and be so far along in it that you never could, even if you put them on a ventilator and gave them time. There was a big debate back in the late 80s, even early 90s, should you even attempt intensive care or all this interventional stuff with somebody who had HIV, because you weren't going to impact the underlying HIV disease. So was it worth putting them in a unit and putting them on a ventilator at great expense in order to give them a little bit longer life, but no potential for any sort of cure?
In the 80s and 90s, HIV was very difficult. We didn't have a test in the beginning. You had people that had risk factors from this unknown disease. I delivered one woman that I was sure had HIV, but 86, 87, the HIV test was new. She ultimately, as soon as the test became available, I was positive for HIV. I delivered 3 of her 6 kids as a family doc.
Patient well-being back then was very different than it is today, because telling a 20-year-old back in 1984 that you had HIV was really telling somebody that they had a death sentence. One of the things that we did with all our patients is we had them, one of the measures in our chart was, well, did they sign a living will? I don't think I've done that. I mean, if I had somebody who was, had advanced disease and multiple comorbidities, that would be something to do. But we did that on every patient. And if you can imagine, asking somebody to get their affairs in order and think about those things so that when they ended up in the hospital and perhaps not being able to make a decision for themselves, it would make it easier for their family members.
Oftentimes they also were disabled, poor, didn't have really the resources to get medical care, so they presented sometimes way too late. And it was a very difficult time as a clinician because it was hospice type work. It was making sure you did everything you could to keep them comfortable, but knowing that the average survivability in the 80s before we had any medication was 6 months or less. So we did certify a lot of people for hospice and try and make sure they were comfortable.
Even in the early years, in the mid-90s, as better medications came out, when people started improving, we didn't know how long people would live for. So it was still it went from like a certain death sentence to like an unstable period where I might be living, I might not be doing well. So as a person volunteering in the early years, and then as a med student, as a resident, you never knew how well patients would do for how long.
I had one gentleman who came up from Atlantic City, who worked at the casinos there, and we would get a fair influx of transfers into Jefferson from different New Jersey hospitals. He worked as a waiter, and he actually came in with sudden loss of vision. Turned out he had CMV retinitis, and within the space of 48 hours got his diagnosis of AIDS and went blind. So very, very fast. Yes, he had been losing weight, but he didn't realize what it was from. Within a few months, he went on to develop eczema all over his body, because we would often see these terrible rashes when the immune system was out of control. And that got super infected with both herpes and a bacteria called Pseudomonas that smells like grapes. So you would walk into the room and you would be just totally overpowered by the smell of grapes from the Pseudomonas. He could still see shapes, and so he always knew when you came in the room because he could see the shadow. And I remember helping the nurses to change the linens, because they had to change them every hour, every 2 hours, because he had weeping sores all over his body. I never heard the man complain. He died one of the most dignified deaths I've ever seen, and the nurses at Jeff were, wonderful taking care of him. But he kept thanking us. Every time I would see him, he would want to grab your hand and say, thank you for taking care of me. And some of them were just like that. So many of them were so heartbreaking because they wanted to live so badly. And we were so desperate that we would try, individual drugs. Then we would add a second drug on, and we'd get another couple months. But always the virus was out ahead of us. Always the virus, could figure out how to become resistant. So everybody knew they were living on borrowed time.
Oftentimes, the most important part of care in the mid to late 80s was countering the fear, the discrimination, making sure people were allowed to work as long as they could. People were worried about headsets. They were worried about keyboards. They were worried about using the same telephone that somebody with HIV might have touched. This was the time when they were keeping children who had HIV because of hemophilia or transfusions out of the school system. They didn't want them to be with normal kids. So there was a lot of advocacy around trying to make sure people understood you didn't get this by casual contact, that this was a sexually transmitted blood-borne disease, and if you stayed away from those two avenues, you didn't have to be fearful of these patients. And yet, fear was the predominant feeling, and in terms of most of the lay public that didn't understand this.
It was a lot of strain. Obviously, the patients were getting the brunt of this, their families, if they had families that would support them, their loved ones, if they had them, that would support them. There was so much stigma and so much prejudice against this. It was really heartfelt seeing it as a doctor and a resident, even hearing inappropriate things from other theoretically mentors or other more senior physicians in the field. It was really testing the nature of who we are as doctors, as care providers, as humans. And I found that very compelling.
The heroes of the HIV epidemic were the medical providers that were dealing with an illness that they couldn't really define, that had very poor outcomes. They were able to administer on a biopsychosocial model, whether they knew it or not, They could write drugs and make diagnoses, but when the family ran into their clinic saying they put Johnny's tray outside on the floor because nobody would go into the room because they're afraid of getting HIV, they continued to do the work. I've always had a family medicine clinic, and before we started Wings in '95, the patients were in family medicine, and I had a couple of my family medicine patients ask me, how can you take care of those people?
It was difficult for CDC and the Public Health Service to really know the extent of the epidemic in some parts of the world because nobody wanted their names turned in. There was, again, that stigma. People, if they were found to be HIV infected, and this is before treatment, we had very little we could do for them, but they stood to lose their job, their loved ones, their families kicked them out if they were found out to be HIV. Nobody wanted them in the house. I used to spend a lot of my time prior to the mid-90s answering questions about somebody who'd taken a sip out of a cup that somebody with HIV had just drunk from.
It was such an interesting area. That's aside from the medical interest and the virology interest about the science around treating HIV, the reason I went into this field and the reason I still to this day find it interesting is there's this incredible overlap between the societal and social stigma and response to HIV still to this day. There's so many people in that generation who were afraid to test because of societal stigma. Nowadays we know so much about testing early, treating early, keeping people healthy from the beginning. There was such a generation in those 10, 20 years of people who had a fear of accessing the medical system. That's part of why I went to this field as a student, is I wanted to be one of those physicians who would take care of patients that were being ignored by the medical system.
The very first research I got to do was on Indinavir, which eventually became one of the first marketed protease inhibitors. So I was coming into it at the time where uniformly everybody died, but I also remember enrolling patients in that trial and seeing the magic of this medicine that was creating what we call Lazarus syndrome. And as Lazarus rose from the grave, here we were seeing people coming back to life because of this magical drug that was about to come out.
And when that happened, as people were living, the numbers of individuals were growing, and we could see what a difference public health had. That's when I think that, at least in my community, that's when the stakeholders came in and said, yes, we want to support this. And that's when I got involved with Ryan White program, and it sort of mushroomed after that.
What the federal government did well in that period of time was pass the CARE Act, the Ryan White Clinical Access Bill, that put about $2 billion into HIV care for the and underinsured, realizing that back then, just like now, 60 to 70% of people with HIV-related disease live at 100% of the federal poverty level or below. That was true then as well, and there was a great deal of difficulty, even when we had medications, of getting that to people. So it was 1989-90 when Senator Kennedy and others put through the Ryan White CARE Act, so that we've finally had a system within the government that allowed us to pay for things like zidovudine and antivirals and things that were available early on. It also was a social support. It was nutrition, it was some transportation, it was psychiatric, psychologic services for the people that needed it. The epidemic back then sorely needed help for these individuals to keep them comfortable and to keep the disease from being spread. So I have to applaud the Congress back then of putting that into place, because it really allowed us to start taking better care of everybody, not just those who had insurance.
Being able to say, we finally know how to treat this disease. We finally have these new drugs. We have these protease inhibitors. They're really working well. You just need to take them every day along with other drugs, and you can get healthy, or you can stay healthy. In most cases, get healthy, because the patients we were treating were usually pretty sick by the time they got in the clinic, and we can get you well. We can bring you back, if you will, and you probably won't die from AIDS anymore.
I think we've learned that infectious diseases affect anybody, that we've learned that it takes a really concerted effort to focus on research and the research process. We don't yet have a cure. I'm excited that there's some very, very promising research going on, and I'm hopeful that in my lifetime we'll have a cure.
The legacy, I think, is, to me, is interdisciplinary care. There's no other disease where the success, we are the original medical home model, and that's being emulated now with a lot of other disease states, but it takes a multi-pronged approach to really address all of those needs. That would be using providers, but also case managers, pharmacists, social workers, mental health care providers. That is really what made this a success, the HIV story a success. And to adapt that model to other epidemics, I think, would be key in making strides in those areas as well.
On the other side, we made a lot of mistakes, moved too slowly, political will was slow. President Reagan didn't mention the word HIV or AIDS while he was a sitting president. Fortunately, he had a Surgeon General by the name of C. Everett Koop, who had recently died, who was changed that position. No one could even remember a Surgeon General prior to him, and he changed that role, and he really was a tremendous leader and a clinician and the nation's doctor and physician first.
I think what we should learn is that we need to operate based on science and evidence and stay as much away from what's the right word, from politics and just sort of social mores making a big impact on what we do. I think we've learned that you need to put some money into the research and the care up front as early as possible if you want to keep any sort of a pandemic like this down. So again, it would have been nice had we been able to help everybody who had it early on with the good tools that we had, or the poor tools, but any tools that we had. We didn't do it as fast as we should have. And I think what we need to help all congressional people and everybody understand is that money's probably better spent up front early on rather than waiting till it's widely disseminated and then trying to do something.
I think the research community could have moved more quickly along with the drugs that we had, and probably a lot fewer lives lost as far as things go. I think what we've gotten right has been the Ryan-White Care Act, I always say signed by the first President Bush, and I think that was a huge success and continues to be so. I think most of us who work in the field know that without that we couldn't continue to do the work that we do as effectively as we do on a week-to-week basis, at least if nothing else, to get patients the medications they need when they don't have insurance coverage.
I think really one of the ways I've sort of protected myself from that is making my own internal rule, and then doing everything that I can for a patient as long as they're alive, and then realizing that I've done what I could, not trying to question whether I should have done something different. It's one of the things I try and teach my residents and students, because I'm still in medical education, is that you do your best and you always work to be your best, but when things don't go the way you would like, when there is a death, realize that you've done it and you've probably learned some things, but don't try and second guess yourself about, oh, what if I'd have done this, what if I'd have done that? And that was a big issue back then, because you did what you thought would help, and then it didn't help and they died and you could feel bad. So I think it's one of the things that's allowed me to stay in this and live through that desperate time to the point now where there's such joy in finding patients, especially if you find them early, getting them on therapy.
I've always been a believer that a big part of health care is care, and that even when you can't offer somebody a curative medication, the caring makes a huge difference. And that, for me in my career and still in my patient practice, makes a big difference.